Sorry, I'll try to talk louder. That better? Okay, so I'll skip that through my first few slides here, but maybe show a nice picture of the UBC campus. This was our building next to the sports fields. And I actually spent a little bit of time in Kelowna too. Again, happen to be next to sports fields. Hopefully see a bit of a theme going here. A bit of time in Rochester, Minnesota, which of course it looks this bright and sunny, 365 days out of the year. Sorry, yeah. There you go. All right, I'll talk loud and keep it interesting. Great. Okay, so yeah, I was at the Mayo Clinic for a few years. I guess not many people have been to Rochester. If they didn't get that joke, it's quite cold and dark and dreary in Rochester a lot of the time. And then I spent 5 years at the University of Waterloo before I came to the University of Calgary here last year. So how I approach my research is I typically ask a very large question, and then we probe it from different aspects. So a theme that's been going on for me since about 2010 now, actually, is how do smaller airways influence the integrated response to exercise? See if I can actually get that away for people. Yeah. So this is just a schematic. This is from a paper we published recently. Just giving the overview when I say, okay, well, how do these smaller airways influence the integrated response? Okay, so we have some anatomical differences or morphological differences. I'm going to go through a few of them here. And these have some functional consequences in terms of the response to exercise. I'm not going to go through every single one of these. And then we have some unknowns. And some of these we have a little bit of information of, and others we really don't have a whole lot at all. So before I go any farther, I do want to make a distinction here about what I'm going to be talking about, specifically the difference between a sexual dimorphism and a sexual difference. Okay, so a sexual dimorphism, the one on the left-hand panel here, okay, this is where the two populations are essentially completely discrete. Now, in reality, there is going to be a little bit of variance in this, and there are, of course, exceptions to the rules. But in general, we have two discrete groups. Okay, for the most part, what I will be talking about today is not sexual dimorphism. What I will be talking about are sex differences. Okay, and with that, the two groups, males and females here, there is differences. You can see, of course, the peak and the average is different between the two, but there's considerable amount of overlap. Okay, so a classic example of that might be height. Okay, if we take everyone in this room and we line them up according to height, we find on average, most likely, the males will probably be a little taller, but there's going to be tons of overlap between the males and females. So that's an important thing that I like to make sure people kind of remember is these are not distinct groups for pretty well everything I'm talking about. Okay, I think this is probably well known to the group, but again, just want to kind of clarify what I'm going to be talking about today. I'm primarily going to be talking about sex differences. So those are biological attributes associated with humans and animals. So these are really the physical and physiological effects. I will be talking very minimally about gender differences. I don't want to minimize this though. You know, I think there's some things that in the last maybe 5 years, we've really actually started to appreciate that these are actually largely gender differences. An example is dyspnea or exercise-induced dyspnea. Probably has a lot to do with gender differences and a lot more minimally sex differences. So why do we even care about sex differences during exercise? So for the younger people in the room, me included, it was not that long ago that it was said that women should not run marathons. Okay, so while many people are familiar with Catherine Switzer, who was the first female to run the Boston Marathon, and very dramatically was kept in it by her boyfriend removing the race coordinator who tried to remove her. Only a few weeks later, the Canadian version of that actually happened. That was Maureen Mancuso ran a marathon. Okay, and she is the distinction, the only Canadian to have a marathon world record in 1967. She did this in 3 hours, 15 minutes and change. Very impressive time. And she actually did this 2 weeks after Catherine ran the Boston Marathon, and she did it at age 13. Okay, Catherine actually ran in this marathon too with her. This was done in Ontario, but she just ran her own marathon a few weeks before, so it took a little easy. What I really liked from the paper that described this is that when she was done, the quote of it says, "The race physician checked her heart right away, noting how much less winded she was compared to her older male counterparts." Okay, so I mean, it was not that long ago that females were told you can't run. We know that it's, of course, absolutely not true. A great example, just last year, the women's marathon world record got dropped considerably. It's now down to 2:09:56. Which I will say there's only one Canadian male who's ever run faster than that. He only did that a few years ago. So this is an incredible time that she just did last year. So before we get into some of the differences, I actually want to highlight a lot of the difference, or a lot of the response to dynamic exercise in terms of the pulmonary response. It's actually not all that different between males and females. Okay, so if we look on the x-axis here, we have percent VO2. So this is just going from rest, exercising harder, harder, harder until maximal exercise. And then we have a bunch of variables here on the y-axis. And these are all just unitless, just showing you the relative change with them. Okay, and a lot of these are what you'd actually typically see in a CPET test or cardiopulmonary exercise test that you would give to, say, a clinical individual too. So, you know, for example, tidal volume increases and then somewhat plateaus, breathing frequency starts off a little slower, goes up. You use a progressively larger amount of your ventilation, and lung volumes kind of change in a predictable manner. And these are, for all intents and purposes, are identical between males and females. There's really not any differences to them. However, the reason I'm here, there are some differences, specifically when we start talking about respiratory muscle energetics. Okay, and these are the ones that I'm going to focus on today. And these are largely the work of breathing, the oxygen cost of respiration, and then muscular recruitment of the various breathing muscles. We have the diaphragm, scalenes, other accessory muscles. So we start off, well, what is this evidence? I'm telling you it's smaller airways. So how do we actually know, or what is the evidence behind these smaller airways in females? Okay, so the first direct anatomical evidence, okay, used a cohort of lung volume matched former smokers. Okay, these are middle-aged to older individuals, and all the airways labeled with the asterisks here, I'll explain the two different asterisks in a second. These were significantly smaller in females. Okay. Well, one asterisk just indicates general, so all the subjects pooled. The other one is for height or lung volume matched. Okay, so that's an important aspect here. We've taken away a lot of the typical sex differences we see. So these are males and females that have the exact same lung size, and yet their airways are still smaller. Okay. The problem with this was these are older and these are former smokers. Okay, so you could kind of think of that as, well, is this a just normal biological difference, or is this something to do with smoking? Is smoking somehow interacting with that? And that was a bit of a confound that kind of stayed in the literature for a while. So while I was at Mayo Clinic, what we did is we took advantage of a large database of CT scans. And what we did is we wanted healthy adult never smokers. Okay, so we had a very large range of individuals here, 19 up to 86, so quite a range. We had about 100 subjects per group. And what we found is essentially the same as the previous study. Okay, when you look at the airways, we have airway luminal area. So it's basically the cross-sectional area of the airways on our y-axis. And then we have different airways on our x-axis. So starting from the trachea, RMB is the right main bronchus, and then all the way down, this is the left lower lobe. And the numbers I have here on the bottom, those are how much smaller relatively the female airways are. So you can see it's on the order of about 20 to 30%. So the female airways are 20 to 30% smaller in height match. So these are people that are of the same height, never smokers. Okay, and when I say healthy here, we took a lot of time to really make sure this cohort was healthy. So what we actually did, because you might say, well, how did you get people to consent to a full chest CT? We didn't. This was a retrospective data set. Okay, so it was actually individuals who came into the ER complaining of chest pain. And Mayo, what they do is they rule out, a number of kind of quicker things, and then their next kind of worry is a pulmonary embolism. And to rule out a pulmonary embolism, you have to do a full chest CT. None of the individuals had a pulmonary embolism. what I had the physicians collaborating with me do is they actually went back in time in their health record and forward in time in their health record. And we eliminated every person that had anything to do with any kind of lung, cardiovascular, any disease. So we started with tens of thousands of subjects and we got 100 to 200 at the end of it. So they eliminated diseases that I'd never even heard of. So we're quite confident this is a good, healthy kind of matched group. And this is a real finding. Why do we care about the airway luminal area? Well, if you look at the resistance through flow, through any tube, this could be a blood vessel, it could be an airway, the radius is by far the most important determinant of resistance, okay? It's to the fourth power. So if you half the radius of something liquid is flowing through, you increase the resistance 16 times. Okay, so it's a profound change in resistance. So there's been a lot of discussion in the last 5-10 years about reproducibility in science and just the ability to reproduce some of these findings. This is especially true in the sports science field. So this is always something that didn't concern us, but we wanted to make sure we weren't overreaching, I guess is another way to put it. So what we actually did over COVID, we couldn't do a lot of other things, is we wanted to look at any evidence out there of these smaller airways in males and females. Okay, so there wasn't a whole lot. There was our study we did is from individuals from Midwest US, healthy range of ages. This is the previous study I mentioned on subjects from Vancouver, Canada, older ex-smokers. This was done at the University of Cyprus. This was done a few years after my study. Again, healthy individuals, similar rationale of how we developed them. Again, large age range. This one was done a number of years ago, the Martin et al. This was done with a slightly different technique, but it's still got tracheal area. And what you can see here, we have airway luminal area, again, on our y-axis, and A, B, C, D. These are just the different studies. It's quite remarkable how consistent these findings are. Okay, not just that the magnitude of difference between males and females is about the same, but just the actual values are very consistent. Okay, we can actually add a few more since we published this paper. This was done with a colleague of mine, Dr. Molgat Sion, and he used the CanCol database, which is a Canada-wide random sampling of above 40-year-olds. Okay, and those are his data points right there. Again, you can see very consistent in this. And again, actually, even more recently, there was one done, a big study called COPD gene. They were mainly looking at genetics of COPD, but they did happen to have chest CTs. And they noted in one of their papers, the airway luminal size quantified as chest CT were smaller in women than men after accounting for height and lung size. So we have now multiple data sets, multiple large, even including random sampling data sets that are all very much agreeing with these kind of smaller ones that we've done. So we're quite confident that this is a real finding. This is consistent across a lot of groups. The next thing we asked is, okay, well, you notice all these studies were generally done 18, 19-year-olds and older. So we kind of asked, well, are these differences innate? Okay, in other words, when do these differences actually begin? Okay, so to answer that, we use a similar technique, except we look at children. Okay, so we had individuals from 0 all the way up to 18 years of age. And we have our airway area on our y-axis, just showing 3 representative airways here, trachea, right main bronchus, left main bronchus, just all of them showed very similar, but just to fit on the screen here. And what you can see is in the youngest children, the males and females essentially are identical for their airway size. Okay, and this is the same for all the airways we looked at here. Okay, if you notice the line kind of jumps up and down a little bit, that's because this was a cross-sectional study. So, the individuals in this data point are not the same in the later data point. So of course, there's a lot of biological variability. What we did notice though, is once you get around the age 10, 11, 12, 13, the male airways start to get much larger more rapidly than the female airways. And this was consistent across the airways. Now, again, you might say, well, is this a sex difference or is this a size difference? Okay, so just nature of this data, we couldn't lung volume or height match them. So we just did a little bit more of a crude way of doing it and just took an airway index, just took the luminal area divided by height. Okay, so what you can see here is the difference was minimized, but it was still present. Okay, so again, now we have individuals where we've taken away a lot of that effect of height, and there's still these sex differences in airways. And so we concluded this is largely an effect of puberty. This just kind of happens to coincide right with when puberty starts for these individuals. And so this is not an innate thing. In other words, this is not something that individuals are born with or is developed as they're in the womb per se. So given that we have now smaller airways, well, how does that impact the integrated response to exercise? Okay, so the main thing that we look at is the mechanical and metabolic cost of the work of breathing. So in other words, how much energy does it take for you to breathe, and how much oxygen do you need to accomplish that amount of energy? Okay, so you might first go, well, how do you actually quantify this? This is not something that we typically see very often. So we quantify it by taking advantage of a unique little characteristic of anatomy, in that our pleural space, which is what surrounds our lungs, and that's ultimately what we want to measure. We want to measure the pleural pressure, okay? Because as you reduce your pleural pressure, that's how you take a breath in. Okay, the problem with that is you can't just kind of poke a hole through your chest wall. It's going to give you pneumothorax. You can do it, not going to do that in healthy people. However, your esophagus, as you can see right here, this is just a CT cross-section of the individual, lies very close to that pleural space. Okay, there's very little bit of tissue between them. And your esophagus is actually essentially flaccid if you're not swallowing. So your pleural pressure actually gets translated almost perfectly into your esophagus. So what we can do is you can actually measure esophageal pressure. So we put a little balloon-tipped catheter through the person's nose. They take little sips of water. They essentially actually swallow the catheter. Okay, and that sits in the back of their nose, down their throat, and that sits in the lower part of their esophagus. So we can actually get a really good measure of esophageal pressure while the person exercises, does all sorts of things. So this is used clinically, rarely now, but it is used clinically in the ICU. Sometimes it's used for sleep medicine, so it's not completely unheard of, but we do it fairly routinely in our lab. And it's not as bad as it looks. Trust me. So if we look at now, how do we quantify that? Okay, so on our x-axis here, we have volume. So this is lung volume. So the bigger it is, the bigger the breath the individual takes. And on our y-axis, we have our esophageal pressure. So if I just walk you through a single breath here, respiratory people, we like to always flip our axes. Don't ask why, it's just convention. So the individual here takes a breath in. So the lung volume is getting bigger. Okay, and you can see the pressure is getting more negative. They're expanding their thoracic cavity. Okay, and then they breathe out, lung volume is getting smaller, and they're generating more positive pressure. To quantify the work of breathing, you integrate the area inside of that curve. Okay, that's referred to as a pressure volume loop. And so in this example, we have a male and a female. They're both breathing at the same rate, about 70 liters per minute in this case. And I don't need any math for it to be quite obvious that the female loop is much bigger than the male loop. Okay, so it requires more energetics or more energetic work to accomplish the exact same ventilation in females. Okay, and if we look at this across various ventilations, so going from close to zero or near zero, which is our rest, about 5-6 liters per minute, up to very intense exercise that not everybody would even be able to achieve, of 200 liters per minute. You can see at low ventilations, males and females, it's actually very similar to the work of breathing. But as it starts to get greater, we have this increased work in the females. Okay, and on the y-axis here, we have our units of work of breathing. Okay, and so the rationale behind this is at low intensities or very low rates of ventilation, okay, the airflow is just not great enough to actually create a lot of turbulence in the airways. But as we increase our ventilation, airflow becomes much higher. Airflow dynamics in the airways becomes turbulent. And one of the biggest drivers of turbulent flow is actually smaller diameter airways. Okay, so it's these smaller airways that are increasing turbulent flow, which increase the resistive work of breathing. Okay, it's not actually any differences fundamental to the lungs. The lungs themselves are actually very similar between males and females. So the next thing we wanted to do is actually quantify the metabolic cost of breathing. Okay, so how much oxygen does it take to breathe? Okay, so this actually sounds a little simpler than it was. Say, for example, if you want to quantify the metabolic demand of riding a bike, okay, well, you just put a mask on a person, measure the gases come in and out, have them do that. There you go. And that could basically estimate how much the quadriceps or your locomotor muscles are doing it. Well, how do you do that for your respiratory muscles? It's a little harder to isolate them. Okay, so we developed this whole kind of rig where we basically made some custom gas that people breathed in. So we did this because they were going to sit on a bike completely at rest, and they mimicked how they breathe during exercise. Okay, so we had this mimicking software that we made, and we have their pressure volume loops. So we made them mimic their pressure generating capacities. We also had them mimic at the same time their flow volume loops. Okay, so they sat here, stared at the screen, breathed gas that had a little bit of extra CO2 just to make sure they didn't go hypocapnic. Okay, and this is what it looked like. So it's the world's worst video game. They literally sat there for 5 minutes straight and just breathed like that. And they could get real-time feedback for all the kind of respiratory pressures We had about 5 of us all coaching them, breathe deeper, breathe faster, use more diaphragm, use more of this. In the end, we were very confident that they mimicked their breathing during exercise, but of course they are at rest. So any increase in their VO2 during this, minus their resting VO2, is the oxygen cost of their respiratory muscles. Okay, and so when we look at the groups here, again, we have our ventilation on our x-axis going from rest at 0 up to very intense exercise 200. On the left-hand side, we have VO2 of the respiratory muscles. Note this is in absolute units, so milliliters per minute. Okay, and on the other side, we have just males and females. This is at VO2 max, so this is now a relative measure, so it's at their maximal exercise. And this is VO2 RM, so their oxygen consumption of the respiratory muscles, as a % of their total VO2. And I'll explain that more in a second. So if we look at the absolute values, we have absolute over absolute. What you hopefully notice is this looks very similar to the work breathing curve. Okay, and indeed it should, because work is almost perfectly linear related to oxygen consumption. As one goes up, the other has to go up too. And so if it's linear related, what we see is they're very similar at low ventilations. But as ventilation gets higher and that work of breathing gets higher, we indeed saw that the oxygen cost of respiration was higher in females. And so why there's a data point and some errors on each of them. So we had every individual mimicked about 5 or 6 different stages of their ventilation. And then they did that about 5 or 6 times too. So we actually got an average per average stage. And that's what we have here for all the individuals. However, if you look at it very acutely, you might say, well, does this really matter? If I kind of go, well, typical max ventilation of females is around here, around 100, 120 liters per minute. Males maybe around 150 liters per minute. You draw a line across, you say, well, they're both about 400 mils. Who cares, right? They're both consuming the same amount of oxygen. And that would be true. At max exercise, the absolute oxygen consumption is about the same. However, that's probably not the most accurate estimation, because now we have an absolute measure over a relative measure. Okay, so what I think is a more appropriate one is, well, at max exercise, how much oxygen is dedicated to your respiratory muscles? And that's what this is a measure of. So if we get a value of about 10%, which is what you see in males, that means 10% of your VO2 is going towards your respiratory muscles at max exercise. Okay. In females, it's significantly higher. Okay, so instead of it being around 10%, it's closer to about 13% of VO2. Again, I really want to highlight the huge range here. There's a lot of overlap between the males and females. Why that matters is because if we ignore oxygen extraction, so that's the latter part of this equation, this is the Fick equation, VO2 is linear related to the cardiac output. And another way you could write that is VO2 is linear related to blood flow. So in other words, if the males have 10% or approximately 10% of their VO2 dedicated to their respiratory muscles, that probably means 10% of their blood flow is also being dedicated towards their respiratory muscles. Okay, and if it's going to the respiratory muscles, in the case of females, it means it can't go to other muscles. It can't go to locomotor muscles. It can't go to other aspects of the tissue. Okay, so I'm not going to talk about this today, but this actually has implications in terms of chronic heart failure, which I'd be happy to kind of talk to people after about that. So one of the next things we looked at was, how does this actually impact the ability to maintain blood gases during exercise? Okay, or a phenomenon we like to refer to as exercise-induced arterial hypoxemia. Okay, so what we have here is VO2. This is VO2 max for an individual on our x-axis, and we have arterial oxygen tension on our y-axis. So if you actually read a textbook, pretty well every textbook would tell you healthy humans maintain their PaO2 between 90 and 100 millimeters of mercury at sea level during even maximal exercise. That is not entirely true. Okay, so we know this is from we took basically every data point that's ever been published using directly measured arterial blood gases. In the vast majority of individuals, especially males here, okay, yeah, they do maintain it at max exercise around 90 to 100. But when you start getting these highly trained individuals with VO2 maxes in the 60s, 70s, 80s, and above, notice how low their arterial oxygen tension goes. Okay. To the physicians in the room, if somebody walked in with an arterial oxygen tension of 50, 55 millimeters of mercury, I would think you'd be quite concerned. Okay, they would actually probably get admitted pretty quickly at that, again, assuming that they're at sea level. What you notice, however, though, is in the females, Sometimes you get individuals who have relatively modest VO2s, around 40 mils per kilo, yet they're showing quite a large degree of hypoxemia during exercise. Okay, and so we kind of wanted to answer, well, why is that the case? So what we did is we have individuals on a treadmill. They had a soft gel balloon to measure the work of breathing. A little hard to see, but they have an arterial catheter in here. That's a high pressure bag keeping the line patent. We took serial blood gases during exercise. Okay, so this is what it looks like. This is just one of the other subjects here. It's putting the arterial line in. There's the actual arterial line in before it's taped up. And there's just a little sample of an arterial blood gas. Same thing you would see in, in a clinical or intense clinical unit in a hospital. Okay, so we did this serially while during the person is exercising. So that's important. This wasn't stopping the exercise. This is while they were exercising. Okay, so what we did is we actually split the individuals into those who were not flow limited. Okay, so expiratory flow limitation means that they are compromised in their ability to generate airflow. Okay, so if we look at flow limitation, okay, we have expiratory flow on our y-axis, pardon me here, okay, and lung volume on our x. So if you took a big breath in, filled up your lungs completely, okay, you'd be at your highest lung volume. And if I told you to expire as hard and as fast as possible, you generate a lot of airflow, right? You push out the air, and then airflow would kind of go down as you reduce your lung volume. Okay, and we say this outer bound in an individual, it's impenetrable. You cannot breathe outside of that max flow volume loop. Okay, all your combinations of flow and volume have to occur under that. I'll explain what the dotted one is in a second. Okay, so these individuals, you can see all of their breathing is occurring under that max flow volume loop. Now, what we can do experimentally is we actually have them breathe a mixture of helium and oxygen. So that's 21% oxygen, the rest helium. Because helium is less dense, causes less turbulence. That's your key word for it's mimicking increasing airway size. Okay, and it allows you to actually breathe more. It expands your max flow volume capacity, and that's what you can see in that gray shaded area. However, in those who are not flow limited to begin with, nothing happened. Because why would you? I give you an increased ability to breathe more, but if you didn't need to, why would you breathe more? Right? There's no need to do that. So indeed, if you look at their ventilations between the heliox trial and the air trial, they were the same. Okay. However, when you take the individuals who were flow limited, breathing room air, you gave them heliox and you expanded their max flow volume loop, they actually did increase their ventilation. And then we put them back on room air and their ventilation went down because they were mechanically unable to do that. Okay, so essentially what we did here is we tricked, you could think of it as have temporarily bigger airways, and then we reduce those bigger airways. Of course, you can't do that truthfully with your airways, kind of that dynamically, but it's a physiologically analogous stimulus by giving someone heliox. And so what happened? So when we measured the blood gases, when the individuals who were flow limited, they got heliox here, they increased their ventilation, which increased their alveolar PO2, which then increased their arterial PO2. Really want to emphasize it did not eliminate that hypoxemia. Okay, it did not go back up to the resting values, about 95 millimeters of mercury. It just went up a little bit. Okay, but that little increase did have a real increase in their arterial oxygen saturation. Okay, so that's a very typical clinical measure you might make. Okay, so this had a real impact on their ability to oxygenate their muscles. And this, while it looks small, it's not a trivial increase. It's about 1 to 2%. That could increase your VO2 max anywhere from 2 to 5%. Okay, so again, an individual who has, say, lung disease or cardiopulmonary disease, this could be a significant amount. What we focus a lot on is with athletics. If you increase an athlete's VO2 max by 5% overnight, they would be over the moon. Okay, so the last few things I'm going to talk about here is starting now how to integrate breathing and cardiovascular function. I know it's the Libin Cardiovascular Institute, so I wanted to bring in some of that. A problem with that is it can be difficult to tease out how the heart and the lungs impact each other, okay? Because you always have to breathe, and obviously your cardiac function always has to be there. So one way we kind of got around that is we actually wanted to reduce the effect of breathing and see how that changes your cardiac function. Okay, well, how do you reduce the effect of breathing? What we did actually is we built a ventilator that can be used during exercise, and it essentially breathes for an individual. Functionally, this is the same as a ventilator you would see in the ICU, with the difference of we essentially souped it up and allowed it to go up to about 200 liters a minute. Okay, so this is what it looks like. This is a famous respiratory physiologist who actually kind of somewhat invented it many years ago. He came to our lab and he was breathing on it and thought it felt the same. He wasn't a subject in any of the studies, but essentially you're exercising, you're on the bike, doing what you need. And this ventilator is providing most of the ventilatory work. So essentially your respiratory muscles don't have to do anything. Okay, so we're able to see in the absence of respiration, what is the impact of cardiac function? Okay, so this is what it actually looks like in practice. So during the no assist, this is a spontaneous breathing, pressure measured at the mouth. We have our esophageal pressure again on the bottom. Take a breath in, breath out, breath in, breath out. We can see the esophageal pressure gets bigger as they take a breath in. We have these big swings. We turn the ventilator on, and this is what it looks like. Okay, so during a breath in, mouth pressure is now positive because that's the ventilator doing the work for the individual. And again, you can just appreciate how much smaller these esophageal pressure swings are. So we're essentially breathing for the individual. So one thing we questioned was, okay, well, if we eliminate the work of breathing, how does that impact blood flow to the locomotor muscles? Okay, so what we did in this study is we had individuals breathing on the ventilator. We had them during spontaneous breathing, and then we turned the ventilator off. And we also measured blood flow to the quadriceps. And on the other side, you can't quite see it, to an accessory respiratory muscle, the sternocleidomastoid. And how we measured blood flow is we injected a dye called indocyanide green. Okay, so it's a green tracer dye. Functionally, this works the same as a pulse ox, just instead of detecting the red hemoglobin, the sensors detect the green dye that we inject into an individual that then the liver metabolizes in about 5 minutes. Okay, so what we're able to do is get an index of blood flow. And so we were able to do that for the respiratory muscle, sternocleidomastoid. Here's us changing the work of breathing. So 100% would be control. That is when we're not doing anything to it. Anything above, we're actually making it harder to breathe. Anything below, we're making it easier to breathe. Okay, as you would expect, if I make it harder to breathe, your respiratory muscles get more blood flow. Okay, that should make a lot of sense. If you reduce it, there's less blood flow. Just in case people are worried, if you eliminate these two subjects, the finding holds true. The stats are essentially unchanged. We did try that. Can't explain these points, but they don't actually, the relationship is not purely because of those two. And same with these two over here. When we do that, and you look at the locomotor muscle blood flow, so it's the vastus lateralis, you see the opposite bidirectional relationship. So when I increase your work of breathing, you get less blood flow going to your legs. When I decrease your work of breathing, you get more blood flow to your legs. Okay. What I haven't shown you here is that those values, right, kind of that fall on the line, those are all the females. Okay, so I purely just want to highlight here that this finding is actually the same in males and females. This bidirectional relationship comparing blood flow and the work of breathing. Okay, and this is kind of, want to make it clear, this is not everything is a difference. I think it's really important to emphasize that there are a lot of similarities between males and females. Okay, so you might ask, well, how did blood flow actually change? Like, how did it know to go to respiratory muscles or locomotor muscles? So it's previously hypothesized that this was sympathetically mediated. So in other words, it was a sympathetic nervous system that did this. No direct evidence for that. We wanted to address that. So what we did is we had, again, people exercising on a bike, they're breathing on the ventilator, we can change their work of breathing. Hard to see here, but there's a tiny little needle that's in their median nerve. Okay, and that sits right in a sympathetic neuron. And we're able to get a direct recording of their sympathetic nervous system during exercise. Okay, so we had the individuals exercise on a bike, spontaneous breathing. As they're breathing more, work of breathing goes up. We turn on the ventilator, work of breathing goes down. We turn the ventilator off, work of breathing goes up. This is exactly what we've done many times. Sympathetics look almost identical. Okay, as you increase exercise intensity, your sympathetic nervous system starts firing. It's helping direct blood flow. We reduce the work of breathing, your sympathetic nervous system reduces its firing. It's reducing its firing, it's allowing those vessels that are dilating to dilate a little more. In this case, it'd be your locomotor muscles. You take that away, work of breathing goes up, sympathetics increase again. Again, males and females showing nearly an identical response. There are a lot of differences between males and females in terms of, say, sympathetics at rest. A lot of these seem to go away during exercise. Okay, some study we've done recently in the lab. is actually now to look at, well, how does this changing the work of breathing impact your heart specifically, not just peripheral cardiovascular function, but actually your heart. So again, we have it where we have the ventilator. Okay, so it's doing the work for people. You can see these esophageal pressure swings in the middle here are essentially zero, or they're very, very small. And what we found is that that will actually impact your stroke volume. Okay, so if you look in the bottom right-hand panel here, different exercise intensities, proportional assists, so reducing the work of breathing and spontaneous breathing. About 5 to 10% of your stroke volume is related to your breathing. Okay, so in other words, you take away those respiratory-induced changes in your interthoracic pressure, you will actually attenuate your stroke volume, or your breathing is directly impacting your heart. Okay, so this is kind of a schematic. This is my student's first study. Her study she just finished up right now. We're actually now directly comparing males and females with this one. So this is one where you'll just have to stay tuned. Last couple I'm going to talk about. Again, I wanted to talk a little bit more cardiovascular with this. So this is stuff we've done, again, more recently in our lab. We wanted to question, well, how do these beta-adrenergic receptors, how do they impact sex differences in exercise hyperemia or blood flow? And why specifically beta-adrenergic receptors is because it's been shown at rest that males and females actually regulate their blood pressure and blood flow differently due to estrogen upregulating beta-adrenergic receptors. Okay, but we had no idea if that translates into exercise. So what we did, individuals were lying down, they're performing single leg extension. So she's just kicking her leg out here. At the same time, we're ultrasounding the femoral artery. So that gets us a measure of blood flow. It's had a progressive increase in intensity. One day was just a control visit. Another day, which was the day we have pictured here, we're infusing intravenous propranolol. So we actually give a very, very high dose of propranolol, and this completely blocks all beta receptors. Okay, so we eliminate all the beta receptors in the individual, with the idea being if beta receptors were also mediating differences in exercise hyperemia, then if we eliminate those beta receptors, we should show differences in blood flow. Somewhat to our surprise, and again, I want to highlight the similarities between males and females, it did absolutely nothing. Okay, so we have on this axis normalized leg blood flow. Again, we wanted to get rid of the size versus sex effect. So as blood flow per kilogram of tissue. Okay, under the control, as you'd expect, as you increase exercise intensity, blood flow goes up, and that was essentially identical in the males and females. On propranolol, a little hard to see, but there was a little bit of an effect of propranolol. In other words, propranolol reduced the blood flow. But again, you don't even need to look at the statistics to say those are on top of each other. It did not differentially affect males and females. Okay, so while these differences in beta receptors seem to impact resting cardiovascular function, has no difference or no bearing on exercise cardiovascular function. An interesting thing we did note, though, is that the ability for the femoral artery to dilate was actually different due to propranolol. Okay, so when you looked at how the femoral artery dilated during exercise, in males, it only dilated a very minimal amount, and propranolol attenuated it, but not really. In females, there was much more of a profound vasodilation under the control, and propranolol attenuated that. So while the overall blood flow wasn't changed, the actual changes in vascular dynamics were a little different between males and females with the effect of propranolol. So there's probably a little bit more of the story than we don't quite know yet. Last thing I'm going to talk about is another kind of fundamental physiological thing, which is the control of breathing. Okay, so while it's ubiquitous, everyone who exercises will breathe more, we don't actually have a complete understanding of why you breathe more. Okay, and one of the other things we wanted to know is, well, does that differentiate between males and females? So what we did is we had individuals perform low intensity exercise. And what we did is we wanted to manipulate their breathing by making them progressively hypercapnic. Okay, so we increased their CO2 levels about 4 millimeters above baseline, and then we did it again, 7 millimeter baseline. Okay, and so what that does, that's a ventilatory stimulant, makes you breathe more. What we found, and I'll explain the day 2 and 3 in a second, is that there was absolutely no differences between the males, females using birth control and the females not using birth control. In other words, they increased their ventilation about 15%, 10-15% at +4, even more at +7, absolutely no differences between them. The other thing we wanted to evaluate at the same time was a lot of people often, unfortunately, exclude females from a lot of basic physiological research saying, the menstrual cycle impacts too many things, we can't include them. We really wanted to address this and showed it has absolutely no bearing on the control of breathing. Okay, so day 2 and day 3 were at different points of the menstrual cycle for the individuals not taking birth control. For the males, it was a time matched 2 day, or the 2 days were time matched apart. And those taking birth control were again just the similar matched apart while they were taking the active pills. Again, what you can appreciate is that day to day, there was no differences between the groups, and there was no impact of day 3 versus day 2 versus day 3. So in other words, it wasn't like the group not on birth control had a differential effect. And so when we looked at the effect of oxygen 2, we showed the exact same thing. So in other words, it's not just a hypercapnic response, the hypoxic response is also the exact same. Okay, so males and females have this similar sensitivity in terms of their breathing, and there does not appear to be an actual effect of the menstrual cycle. So while again, you do see these differences at rest, they are completely abolished during exercise. And so I think that's important, again, to highlight that, a lot of the fundamental physiology is the same between males and females. And so the last thing I'll leave you with here is we've been looking at the hypercapnic sensitivity. So we have that measured here on the y-axis. Higher the number, the more sensitive you are to CO2. Okay, and what we showed is that your sensitivity increases as you're prepared to exercise. So you go from resting on a chair, you have the lowest sensitivity. And as you increase, going from resting on a bike, you get a bit of an anticipatory response, and then just moving your legs, 0 watts, that sensitivity goes up. Okay, well, you might say, well, the males were higher than the females. This is entirely accounted for a size effect. We scaled out size and made this relative to body mass. They're identical. And importantly, the temporal change was the same. Okay, the slope of these lines was not different between males and females. And then the other thing we looked at, well, how does progressive exercise change it? Didn't change it in the males, or didn't change it in the males, didn't change it in the females. So these fundamental exercise physiological responses are not actually different. And a lot of these things are just size effects. Okay, so a few take-home messages for everybody. Females have smaller conducting airways than males. This is true even when you height or lung volume match individuals. These smaller conducting airways impact some of the aspects of the integrated pulmonary response, not all of them, okay, but some of them. But many of the fundamental exercise responses are not actually different between males or females. Okay, when I say fundamental, I mean things as simple as breathing more, increasing your ventilation, or the blood flow increasing, or blood pressure changing with exercise. Fundamentally, these are not different, and they are not regulated any different between the sexes during exercise. And so to go along with that, I think you should always be aware of the size versus sex effects. Some of these are size effect, some of them are sex effect, and a lot of them are actually a combination of size and sex effect. So with that, I'd just like to thank various undergrad, master's, PhD students, all the funding sources. As you can imagine, a lot of these studies were fairly invasive, so big thank you to the participants, and then a lot of the physicians over the years that have helped us with these studies. With that, I'm happy to answer any questions.